Good afternoon, everyone. Can you hear me okay? You're good. Excellent. So I'm Catherine Sorsdahl, and I'm the co-director of the Alan J. Flisher Center for Public Mental Health. And as you know, our center is a collaboration between the psychology department at Stellenbosch and us here in psychiatry. And it's a really great pleasure to welcome you all to this annual occasion. So this memorial lecture is held annually to honor the legacy of Professor Alan J. Flisher. He's really a pioneer in the field that we all work in. His contributions as a distinguished scientist, academic, mentor, and mental health professional have really left the field going so much better. He's really made such an impact on the field of public mental health. I'd also like to welcome his sister, who's here today, and a few other of his family members that are online today, so really welcome. And thank you all for being here today to really, I guess, pay tribute to the work of Alan J. Flisher. So without further delay, I am going to introduce you to our speaker, which I think many of you already know, but I still have to go through the processes. So Leslie Swartz is a clinical psychologist and professor of psychology at Stellenbosch University, one of the founding members of our center. He and Alan did their undergraduate studies together at UCT in math and psychology. So they both have some very interesting background stories to tell you if you do get to spend some time with them. Leslie is an editor-in-chief of the South African Journal of Science and the Scandinavian Journal of Disability Research. So you can see he really is a pioneer in his field. And much of his current work is really focusing on building the capacity of emerging researchers. And I'm sure that there's many of us in the room today who've had the privilege of being mentored by Leslie in so many different ways, not just in research, but also in kind of understanding academic complexities and contexts. So most of his biggest research project at the moment is addressing language barriers to mental health. So I'm really excited today. It's going to be a really exciting lecture. He'll have some time to give his time for his presentation, and then we'll have some time for questions, and then a little snack and lunch at the end for those who are here with us today. So over to you.
Am I standing in the right place? I go back to times when we didn't have all of this fancy thing. Thank you very much, Kat. Thank you very much for inviting me. I did fight Kat when she said that I don't know, and some of your friends said that I should do this lecture because I feel in some ways, I feel incredibly honored. So thank you. Thank you for twisting my arm. I also feel very emotional because of the memory of Alan, and it's wonderful that some family members are here and online. And it just seems so odd that so many people whose lives he has touched, including in this room, don't actually remember him. It's long enough ago that that he died. I've also kind of had a slightly strange path, if you could call it a path, many paths in global mental health, which is why in sheer self-defense, I have called this talk all over the place. But I'm very pleased to be called undisciplined because that's very much who I am. And I would like to acknowledge somebody has to live with that all the time, which is Louise Frankel. She knows what my study looks like. What do I? This one, that one. Oh, sorry. Okay. So Kat has said some of this is from the Alan J. Flisher website. She's said some of the official things, but there are so many people in this room who were affected emotionally by knowing Alan. I had a whole lot of photographs of him when we were much younger. We were undergraduate students together. We both had long hair And I remember a particular picture of Alan in those awful 70s shiny running shorts that we used to wear. My computer was stolen, so I don't have that. I'm very grateful to Margie Schneider for who unfortunately can't be here in person today, for giving me some photographs, all a bit more recent from the Alan I Remember. And the Alan I Remember was just a really good friend, which is what he continued to be. A person of principle, creative, interested, interesting, prepared to change direction. He did a whole degree in clinical psychology, then started medicine, did psychiatry, had I don't know how many degrees from UCT, always willing to learn, always willing to change direction, change his mind. And he changed the world, actually. He certainly changed my world. So, and I think the world of many of us and many more people, a lot of people without voice. So I'm going to talk a little bit about some of the things that that have affected me in my rather strange kind of journey. And global mental health did start off as very undisciplined, as a critique, really, of where we come from. And where we come from is kind of embarrassing, but it's important to acknowledge. We come from colonial histories of encounters with the other, these strange people who look different to these alienists, as psychiatrists were in the 19th century, who went on various expeditions and encountered people that they couldn't understand. And there was a kind of medical, but also prurient interest in what quite early on came to be called culture-bound syndromes. In this tribe, they run around and do things in a funny way. When people later looked at some of the data on which the statement in this tribe was made, it was often on the basis of very little observation. But an entire field persists today on that kind of interest in the other. It was a field also which pathologized revolt and resistance. So quite early on, doing things that colonists could not understand was seen as a problem. And the most famous of these is the American psychiatric diagnosis of drapetomania, which many of you will be familiar with, which is the illness which slaves had in North America. It was an uncontrollable urge to run away. But that was in the, it was in the nosology of the day. So we're kind of complicit in all of this. And this sort of, it persists in interesting ways. I took this slide earlier this year off the Belgian Royal Academy website. It's changed. I checked it today. And it's much less interesting than it was. I don't think they were listening to my Royal Society of South Africa talk earlier this year, but something made them change. And they have a unit which is involved in promoting scientific knowledge in overseas regions. And you can just see by the image what is being reproduced. The image of a certain kind of rurality, of poverty, and so on. And this Royal Academy has had various name changes. It was renamed as the Royal Academy of Colonial Sciences in Belgium in 1954, and it's now the Royal Academy for Overseas Sciences, and that's persisted since 1959. And I'm not going to go into the question of whether there is such a thing as an overseas science and what is science, and whether overseas people are allowed to participate in the big sciences. But we seem to have captured the word global, which is something to kind of come to. So all of these international stories are also South African stories. We've got a history of colonial conquest, the building of asylums, a very strong history, particularly in the university I now work in, of racism and race science. I don't know how many of you are aware of the artifacts that were found not very long ago in our archives. I'm a professor of psychology at Stellenbosch University in the long tradition of H.F. Verwoerd, who some of you will remember. He was also a professor of psychology at Stellenbosch University, also published in the South African Journal of Science, but that's another story. But mixed in with this was a sincere wish to understand, to understand the other, not just to categorize the other. Social work really got started formally as a profession at Stellenbosch University with the Carnegie Commission on Poor Whites. R.W. Wilcox, who was the supervisor of H.F. Verwoerd, came to the conclusion that really at the crux of the poor white problem in South Africa was miscegenation, which is sex across the color bar. Social work actually has a much, much longer also history in South Africa, going back many generations. But the formal history of social work was looking at the poor white problem. Apartheid was excellent in abusing cultural relativism. We don't give people services because they have their own indigenous healers, or what at the time were called witch doctors. They're not interested in Western science. A lot of the way in which the mental health of mine workers was thought about had to do with the construct of acculturative stress. So you take people, put them in compounds with terrible sanitation, literally not having a bed to sleep in, as Mampila Rampele has spoken about in a book called A Bed of One's Own. And then you look at their reaction to this and you say, well, this is obvious. It's a translation from a rural African culture into a modern Western culture. There then came, and this was part of our generation with Alan, it was always there, but an increasingly loud critique and rebellion, the challenges of adapting to a new democracy, which Alan, I think, took on really well. I took on less well. I found it very difficult, actually, to move from being on the side to now being part of the center. We have wonderful progress. I see there's some people who wrote our progressive policies, innovation, and current challenges of delivery, disillusionment, and worry over where we're going. And I'll come to it, but this is also a particular day in world history, because on the other side of the Atlantic, there is a very crucial election happening, which has huge implications for global mental health. So I moved from centrally being interested in global mental health to broadening to disability. And I hope I'll show that it's a jump to the left, but it makes sense to me. And I want to quote from Imada. She has some very other good books on disability, but I think she tells us something which is very important. She says, in the broader sense, colonialism demanded able body minds from subordinated subjects. Colonial projects imposed impossible regimes and expectations of self-regulation its subjects would not be able to perform. Thus, the colonized were always already figured and constituted as disabled, whether because of their perceived unproductivity as laborers, their embodied racial and sexual differences, the unchaste proclivities of their women, their susceptibility to moral contagion, infectious diseases, or inability to learn. But this is where I think we really need to learn something from her. In the undulating colonial hall of mirrors, the inversion of these qualities, too much learning, the adoption of European manners, for example, could mean colonized people had failed to maintain the essential vigor of their race. Thus, we begin to see how disability operated as a flexible and capacious concept and a very useful weapon during the incarceration, elimination, and removal of unfit colonial others. And something I took out of this talk, but if you look at the history of the use of clever blacks by Jacob Zuma as a concept, you actually see it kind of echoed here, because real blacks, according to him, are not clever. Real blacks who question him. So a little bit for this audience about the United Nations Convention on the Rights of Persons with Disability. So Article 1 says, the purpose of the convention is to promote, protect, and ensure full and equal enjoyment of all human rights and freedoms by all persons with disabilities, and to promote respect for their inherent dignity. And people say, what's this got to do with people with mental disorders? But it includes people who have with long-term physical, mental, intellectual, or sensory impairments, which in interaction, I'll come to this, with various barriers may hinder full and effective participation on an equal basis. What's key about this, if we're going to think about global mental health? The first thing that I think is really important is that, as Alan Yeti has said, disability is a relational construct. It doesn't exist within people, it exists between people. It is in the interaction. And the environment is not just the physical environment. One often would use the example of a building that doesn't have a lift, and so a wheelchair user cannot access it. And so they are disabled in that building, but maybe not in another building which is accessible. But that environment is physical and social, and probably most fundamentally attitudinal. So there's an emphasis on participation and an emphasis on, to quote from the disability rights movement, it's now become much more general, of the 1970s. Nothing about us without us. So knowledges about disability should be co-constructed with people with disabilities, and context matters, and context needs to be carefully looked at, which I think is really kind of challenging for all of us. But I want to give an example from somebody I was lucky enough who's in the Department of Psychology at UCT, and was in the Department of Psychiatry and Mental Health. And this is an example from the work of Siyabulela Kabila. I was lucky enough to work with him. If you live in Khayelitsha and you have a child with intellectual disability, you're very close to the excellent services at Lentegeur Hospital. Absolutely excellent services. It shouldn't be a problem. Imagine that this child has something of a mobility impairment and is also drools a bit, might be loud, make funny noises, might smell a bit. You've got to get your child to the services at Lentegeur Hospital. It's close by. Taking your child out of your shack will immediately expose you in a way that I wouldn't have to think about those things as a parent. I mean, I drive my car into the garage, etc. I could put my child into the car and so on. You're immediately exposed to social barriers, potentially. There are barriers getting onto the taxi. If you have any kind of mobility device, you might be charged extra. People in the taxi, quite rightly, might not want to be in a taxi with a child who's not properly continent, and so on, and so on, and so on. To get from Khayelitsha, from the Year 2 taxi rank, to Lentegeur, and many of us here have been to Lentegeur, will often take 3 taxis. Just imagine getting your child on and off 3 taxis to go 10 kilometers. Doesn't stop there. If you're lucky, you get dropped off at Liberty Promenade at the taxi rank. Then somehow you've got to get to Lentegeur. The taxis, some of the taxis, not the taxi you were in, may be driving on the pavement that day. You've got a child with ADHD. You're hanging on to your child. You're exhausted. You've got to get to Lentegeur. Then when you get to Lentegeur, you've got to get from the gate of Lentegeur right to the intellectual disability services. When we think about the low rates, which Siyabonela informed me of repeat visits of parents of children with intellectual disability at Lentegeur Hospital, we tend to think, what are we doing wrong as clinicians? And why are we not nicer? And so on and so forth. There are a whole range of things which happen that would certainly disincentivize me as this parent from ever coming back. And often when I give introductory talks on disability in low resource context, I always say, if you understand 3 T's, you'll understand disability in Africa. So I've spoken to the example of transport. If you look at the bottom, this picture at the bottom was on the cover of the Daily Dispatch in the Eastern Cape, that somebody getting to a health clinic in the Eastern Cape on a wheelbarrow. The issue of toilets, Coulson, Nabi and Matsebe, in a book that we edited, looked at the situation of RDP houses. We were so excited to have RDP houses when we got democracy in South Africa, not accessible to wheelchair users who lived in those houses. And then crucially, I think crucially for health services is the question of time. And some of the work we did in Malawi expresses this well. This one will delay us. So we have to think about contextual realities and resource realities. We're very big in global mental health about issues of integration. Some work we did quite some time ago involved a school, which used to be a whites-only school for children with cerebral palsy, which had fantastic services for sport, adaptive sport for children with cerebral palsy. We changed our country, we wanted equality, we integrated the school, brought in people with other disabilities. The children with cerebral palsy are still there, very much in the minority. The school is majority Black. There are no adaptive sport facilities, or there weren't when we did our research, for kids with cerebral palsy in that school because of economies of scale. So there were huge gains of getting kids who wouldn't be in school at all, but losing something through the integration project. So sadly, the children told us there's soccer, but we have to watch. We speak often, as we should, about the integration of mental health into primary health care. It's important, and many of you have done the best work. I can see you before me on this, for resource efficiency in the context of deinstitutionalization, for convenience and accessibility. We've got important work on task sharing, the role of nurses, community health workers, and others. We make assumptions. I haven't been able to find evidence for, we often assume we're going to put people with mental health problems in the same queue as everyone else, and it's going to improve relationships and destigmatize it. If you remember, Kat, I asked you, and we make an assumption. But in fact, if you look at the literature on intergroup contact, you need more than just contact to destigmatize. And I haven't been able to find any evidence that the destigmatization often occurs. I'm open for people to change my mind about that. I hope I'm wrong. The primary experience of many people in our health systems, regardless, is the experience of waiting. So before people get to us as clinicians, what happens in the queue? Work that Haley McGregor and I did ages ago looked at the dangers of queuing. for people picked off as vulnerable in the dark in Khayelitsha. It's often in the nature of waiting in the queue. It's hard for you if you've got a mental disorder actually to wait with other people. Devon Roll, who's one of my current PhD students, is working in the Eastern Cape. He's the first psychologist to be employed in part-time, and they're waiting to sign whether he's allowed to stay on in his job. He's working as a psychologist in the Eastern Cape, first time ever in his unit, and the staff that he works with are very dissatisfied. And the reasons for their dissatisfaction are quite interesting. One of the facility managers says, I've been here for 16 years. At that time, it wasn't yet integrated. There was a dedicated nurse who did it, the mental health care, and they went to the different villages. She had her special people. There are all sorts of problems with the language here. But now everything is just disintegrated and collapsed because of integration, according to her. I've got good news. What do people do in this kind of context? There are these strange processes of a process I call creative resegregation. On the left, there is a quote from a woman with bipolar disorder who is asked when she gets to the pharmacist, you must say your diagnosis and say it so I can hear. You know, it's not intentionally stigmatizing, but she'd rather not, actually. And people find it difficult to come for their pills together with other people. It works on me, sir, because it's my date. The waiting doesn't make it right with me. Everywhere I go, I have to wait. There, when I almost stand behind, I get sicker. And then I have to take pills now, and I have to take pills at home. Then I get those eye problems again, which, you know, the eye problems, well, integrated service, we hope the eye problems are dealt with. What the nurses actually started doing there was they started resegregating the queue and inviting people with mental disorders to come in the afternoons when it was quieter. And the same person says, yes, sir, they helped me after this. They helped me. They no longer make me wait for other people who come here. I get a date. I come here. I don't wait so long. I said once, I come in the afternoon, and now there are not so many people. Much more happy. I mean, the sort of irony in terms of all the things that we're trying to do. And the issue of waiting is something that is also relevant to something which I've spent quite a lot of my professional life on, which is the question of language and broader questions about care and task shifting in Africa. The current project that I'm working on at the moment, we have some refugees and migrants to South Africa who tell us stories of arriving at the primary care clinics with really, really nice nursing staff who really want to help everybody. These are not bad people who don't care. Very traumatized, all of them. And then being confronted with somebody they can't speak to. The person speaks Kinyarwanda or Kiswahili or a range of other languages that'll be familiar to you. So they kindly say, let me deal with everybody else because you're going to take long and wait all day for me. When it gets to the end of the day, then they'll say, sorry, it's the end of time. I'm tired. Will you come back tomorrow? And that's the end of their contact with primary care. And these are people that actually with serious mental health issues that we talk about task shifting, and they're not going to be seen at any point by mental health services. So these are the kind of issues that we really have to kind of think about. We have interesting issues that about task shifting, unplanned and invisible task shifting. So some of the work that Janine Smith did, she was, some of you will remember her, she trained here as a psychologist. She collected the data before she started her clinical training. And I always think she collected better data because she wasn't already schooled into only seeing things as a clinician sees them. So she went into the wards and spoke with the cleaners, and she saw something. I'd been in and out of the same wards for years. She saw something and got data that I would never have got. And she found that cleaners were often doing interpreting, but she found other things like cleaners. There was a kind of hidden ward round. So where cleaners you were assigned your patient, you would discuss your patient with the other cleaners, you would make sure if you had some feedback to give to the doctors that you would get close to the doctor, because the doctor wouldn't call you, and then you could sort of mention to those. So there's this wonderful line is, I was doing my sweeping and I made sure that I swept more closely to the doctor so I could tell the doctor about. They were doing much more than interpreting in the context of formal interviews. We've just, together with Amakosi Pilasanda Sitole and Tessa Root, we've just got 2 publications out from our work at this hospital on the role the security guards play. And of course, as anybody knows, security guards play multiple hidden roles, including that of interpreting. And there's some pride and pleasure in interpreting, but given that the security guard yesterday was working at Pick n Pay and today is at Falkenberg and tomorrow will be at Clicks, they're kind of ethical concerns. We did some work at Alexandra Hospital with Nico Hlongwani, where clinicians desperate to be able to understand their patients would be saying to security guards, what should I do about the medication for this patient? Now, those aren't bad clinicians, and they aren't bad security guards. But these are the issues that we have to deal with. We don't know formally, whether that actually changed prescription practices and so on. But what do you do when you feel, as many of you know, so completely at sea with people that you work with? And in fact, I just want to emphasize that when you speak, as we have done, to service providers about their work, we even in the piece at the bottom there with Sonia Killian and Borga Beleza and I still can't forgive him for going to UKZN, but anyway. But we used a validated measure of turn taking in clinical interviews, and we had recorded interviews done through interpreters, and the clinicians were actually doing everything that they were supposed to do. They scored extremely well, but weren't able to get a story because they're working with untrained interpreters. So none of this is about personal failings or a wish not to understand patients and so on. I'm very pleased Irisha Benjamin is here. She may recognize this, but Irisha was central in our pilot project on language barriers in health, which we reported on some years ago. Irisha, I could force you to give a talk here, but I won't. But there are lots of success stories about increasing access, but a very uneasy fit. I don't think we really understood the organizational context enough, and the barriers, and the issue of when we gave extra, well, Irisha, I mean, who wouldn't want to be supervised by Irisha? But when Irisha gave extra supervision to the interpreters, there was a lot of envy because other staff would say, I'm not getting a chance to leave the ward and get supervision. Why should they have it? The real work being seen is help me with the filing, get this onto the computer. Don't waste your time. The issue of time and waiting, which is a major issue, is when the clinician needs the interpreter's not there, and when the interpreter has time, the clinician's not there. The lack of career pathing for people to make the services accessible for us, and the question of sustainability. Never to be defeated, though. We are, they say, if something doesn't succeed, just do it again. So we're currently in the planning stages. And many thanks to Carol Dean and others for supporting us with this. We're in very early stages of a project which is an offshoot of my largest research project at the moment, which and I know some of my friends and co-conspirators are online, the migration and mental health project, where we are hoping to pilot. I hope Keshav's not on the line. He hates it when I call this the tech company that we work with has got a platform that looks very much like Uber for interpreters. So when you need an interpreter, you know, he hates it when I call it that, but you'll understand that. And we're just doing the ethics proposals should be ready by next week in the hope that we could do a larger evaluation project to see if there's a way easily in our context to match people. It's much easier said than done. It's much easier to do so. Keshav works largely in Europe. Their business is in Switzerland. Getting from place to place is just much less of an issue. And getting bandwidth so that if you're doing, because this can also do online interpret, you can do it using the cell phone. But finding a place where you have airtime, proper internet, etc., etc., is just much less of an issue in Switzerland than it is here. We've got lots to kind of look at, but where is the disability? It's in the relationship between the person and the environment. Sometimes I think disability ideologies have a difficult relationship with global mental health. The disability rights movement of the 1970s and beyond, very much in keeping with other liberation movements, was spearheaded by people with physical disabilities. And I don't know how many people know, but like all good things, well, and some bad things, if I think about who's likely to be the Minister of Finance in North America at the moment. He was a South African export, Vic Finkelstein, who was absolutely central to the formation of the disability movement in the United Kingdom, had been kicked out of South Africa by the apartheid government because of his work in the anti-apartheid struggle here. But you'll see even very early on, Vic is talking specifically, and I've added the yellow parts, the thing that unites us together is society that discriminates against us, disables people with different, but he says physical impairments, and he says physical impairments, physical status. It would be possible for him to be able-bodied in a fully accessible world. But that's the metaphor on which a lot of the disability rights movement was built. And one will hear within the disability rights movement often and still many people saying, I may be disabled, but I'm not mad and I'm not stupid. It was just wonderful because my research assistant, when I was doing work with people who largely had physical and sensory impairments, revealed after 4 years of working together, she put up her hand and she said, I'm tired of hearing this, I am mad, I have bipolar disorder. And they said, well, we didn't mean you, we didn't mean, that usual sort of thing, but they were completely amazed that somebody with bipolar disorder had managed to train them and so on and so forth. And it was only later in the history of the disability movement that people started to look more at intellectual disability, at what we call psychosocial disability, or some people would call mental disorder, but even psycho-emotional disability, which the feminist disability studies scholars started talking about what it does to you, even if you do not have a mental disorder, to live with such discrimination. to be dealt with disrespect and so on. And if you track the history of liberation movements, including in our own country, there is often early on a lack of a wish to engage with things that are seen as weak, like these emotional things. That was certainly my experience during the kind of struggle years. Things have got much more complicated. It's good that they've got much more complicated. And within the United Nations Convention on the Rights of Persons with Disabilities, to which South Africa is a signatory, and a signatory to what's called the optional protocol. And the optional protocol means that if somebody with a disability, and that would include somebody with a mental disorder, does not get properly treated here in our country, they have recourse actually to go to the United, as they have done. And Emma knows much more about this than I do. But one of the areas that's really complicated for us and that I don't think that we've solved is this question about capacity. And I'm quite intimidated to see some experts on this in the room. The question of capacity, and there is a general comment on the question of capacity, because the UNCRPD does not believe in substituted decision-making on behalf of people, including people who are experience what you and I would call psychosis. They talk about support in the exercise of legal capacity, which can be done in a whole range of ways: peer support, advocacy, advanced planning, stating wills and preferences, and so on, so that people can make decisions, for example, about involuntary care, which is an area that clearly those of us who share the values of global mental health have problems with, but remains, I think, an important reality. And here I'm interested in the work of Alex Freeman, who's not here, but I think he has a support group here today, who I think is doing some quite amazing work actually on looking at the question of involuntary care. And what I think he's been able to show through very careful, empathic work on a very small scale, so we need to know much more about this, is that everybody finds involuntary care really, really difficult. So he's spoken to people with psychosocial conditions, what you and I might call psychosis, their family members, and psychiatrists who are involved in their hospitalization and care. They all find it stressful, they find it difficult, they find it ethically challenging, and they cannot suggest an alternative that they think would work in South Africa. So so we may not always be in an easy position in South Africa and similar countries to act fully in concert with what we'd like to act in concert with, the General Comment 1 provisions, especially in low-resourced and multilingual contexts. I think we've got lots more work to do about that. Luckily for us, there are people who are really giving us a lot of advocacy and aspiration. Many of you will recognize Inga Peterson's name as the senior author of this. They published interesting op-ed piece, an important op-ed piece last year about a liberatory global mental health, saying how far we've come, but also how far we have to go, the importance of the voices and perceptions of people with lived experience in low and middle income countries, the human rights issues, the funding issues, which many people in this room have worked very hard to change, and political mobilization, and so on. But it's kind of, for me, when I look at this, it's hard to take up this challenge, actually. It's an important challenge, but I think it's hard to take it up. And here are some of the reasons why I find it hard. I don't think we shouldn't. I think we should. But it's important to recognize that it's hard. We need to think about who's allowed to speak on behalf of whom. And we are beyond, I hope, the idea of white psychologists like me speaking on behalf of Black people with mental disorder, but it doesn't take the problem away. It complexifies the problem. Yeah, so how do we preserve an understanding of diversity and intersectionality within different marginalized groups? How do we understand gender within the context of serious mental disorder? Who speaks? Who's allowed to speak? The silence of fathers of children with intellectual disability, the flight of fathers of children with intellectual disability, which is often portrayed simply as a moral failing on the part of those fathers. But what's happening in terms of their relationship with the environment, their care, their masculinity, and so on. I mean, I'm deliberately taking the obverse because obviously it's mainly women, and I mean, care is undertaken mainly by women. How do we take epistemic exclusion and violence seriously and still reap the benefits of all the amazing things? I mean, the University of Cape Town has this amazing neuroscience institute that's doing this incredibly important cutting edge work. Not everybody's going to understand that. And that's actually, doesn't make it bad, it makes it good. If our understanding is broad and contextual, how do we maintain respect for the specific forms of experience of often the most marginalized people and what many of us would call illness, even though that may not be fashionable? And as you'll be relieved to know I'm getting closer to the end. Not too bad. I just want to talk about three areas. You may be exhausted, but the list isn't. So I'm going to talk about medicalization, clearly medicalization of social issues and nonconformity. I mean, it's clearly a problem. It still happens. Look at what's happening in the American kind of election. But even those amongst those who are critics of medicalization, it's been useful. Like the birth of PTSD as a category came from largely, I mean, not only, but Lifton was central in his, in the creation of PTSD as a disorder. He was a psychiatrist. He was keenly interested in social issues. He wrote about the Nazi doctors, Hiroshima, et cetera, We used it, during apartheid. Jackie Hawes not here, so I can misquote her, but she says, this is from an article of her and Jackie and Bovey, having a biological driver of a condition doesn't discount the social and the psychological drivers, as even a passing understanding of epidemiology shows, even when considering medical conditions such as hypertension and cancer. Healthcare personnel are trained to hold multiple drivers in mind simultaneously. I've emphasized that because I hope that is true. I hope if global mental health has had sort of an impact on the way that we think as professionals, that is true. We have category drifts as a big challenge. I don't have time to go into this, but what are we talking about? We've moved from mental illness, mental disorder, psychosocial disability, psycho-emotional. These are all sort of overlapping terms. I've come to the clinic for my mental health. Give me pills for my mental health. I mean, we've all heard this. What's the difference between mental health and wellness? I just recently happened to be one of the better PhDs that I've ever examined. I was at a Viva, not in this country, so it's not somebody that you know. And I said, you're talking about mental health in this page, you're talking about wellness on that page. What's the difference? And they couldn't tell me the difference. So is that a problem? Isn't it a problem? I'm not sure. But it raises questions about what is our particular kind of contribution. We're in the age of populism, I don't have to tell you, where there's this bifurcation according to there's sort of two pieces to the most definitions of populism. The one is the difference between the elites who are powerful, corrupt, and homogenous, and the people who are oppressed, virtuous, and also homogenous. The second thing is that or the consequence of the split is that representatives of oppressed groups are thought inevitably to express the wishes of those groups accurately, that people from elite backgrounds or professions cannot have the interests of oppressed groups at heart in any way. There can't be oppression within oppressed groups, or oppression within oppressed groups must be tolerated or excused. Any of you familiar with the gender politics of the struggle in South Africa, which I was very much part of, will know some of the stories there. And one of the most difficult, I think, which I think is often unconscious, is that members of elites must pretend they don't have, that they're not members of that elite somehow. They must disavow their knowledge and expertise as though it's going to solve that issue of power. And the people always knew better. So we know about right-wing populism, the Trumpism, climate change denialism, the anti-vax. Fauci is going, according to some people, is going to be put on trial as a serial killer. The prospect of Robert Fitzgerald Kennedy Jr. as being in charge of health in the richest country in the world, but we have it in South Africa too. It enabled more than 300,000 deaths through HIV denialism, through Matu Chabalala Msimang and Thabo Mbeki. And even close to home, not that that's not part of our home, with the language that was used when the Society of Psychiatrists said there's going to be a problem to the Gauteng government around Esidimeni. There was a populist response. Good people in our communities know how to care about people. You're imposing something. There was a kind of a populist, also neoliberal response. And I think we need to think about, do we have populist threads in our own work in global mental health? But also just circling back, it's clear that professionals don't know everything. Epistemic exclusion is real. I think we're in a moment in organized psychology in South Africa where during the struggle, we were talking about giving psychology away, but actually we're much more concerned with our own power now. And with our obsession with professional categories and different subcategories and balkanization of knowledges. I don't know if there are any occupational therapists here today, but I mean, the importance of occupation has not been taken up by people generally in the higher status professions because it comes from a lower status, largely female-dominated profession. And I mean, let's have a fight about who's a counseling psychologist and who's a clinical psychologist. And even in really important work, which is breaking boundaries and did break boundaries, there was a group of amazing psychologists who supported the families in the context of Esidimeni and who gave evidence and who helped those survivors a great deal. But if you look at what they say, something else is happening as well. It would not be possible for these families to do this work without professional assistance, so that they need more help. They need to be assessed. The indication, the individuals affected by this trauma, life Esidimeni trauma, need long-term psychotherapy. It must be done by people who work psychoanalytically and who've had experience of trauma intervention, et cetera, et cetera, et cetera. Something's happening there about, how are the families, the survivors of life Esidimeni, going to get the transport to come to even free psychoanalytic sessions with somebody who can't speak their language? So, I mean, within the process of our trying to move outside our bound and do fantastic work they did. But look at it, we haven't lost ourselves somehow. By the way, this book, for any of you interested, by Harriet Coleman and Mark Lewis, who are not psychologists or mental health professionals. So, to me, just looking at all of you and knowing some of the people online, the best testaments, I think, to Alan is the work of people here today who've done much more than I have to promote global mental health. But I hope I've shown that in building the future, we also reproduce the past. We can't help it, but we need to recognize it. I think that we need to keep some balance between the particular that we know as people in mental health and the general that we always need to know more about. And I'm nearly 70 years old, so the next generation, I hope you will take Alan's legacy forward. Thanks very much.
Thank you so much, Leslie, for such an inspiring talk and thought-provoking as usual. We have to have time for questions. So
Okay.
I'm going to keep you here for a little bit longer.
Sorry.
So if anyone, sorry.
She didn't say thank you.
So no, it's my fault. I'm keeping everyone here. It's fine. So if anybody has any questions, anyone in the room or anyone online, please just type it in the chat and we will read it out. But yeah, any questions? I just want to know how you bring all these complexities together, Leslie, and you make it seem accessible and integratable, and you point out all the problems, but we still feel optimistic about going forward. So I'm just wondering, how do you pass on that skill to the next generation?
Well, first of all, thank you very much. I mean, you obviously know how to flatter people. So that's really we have that skill. Sheer panic, I think. It's very kind of you to say that, but I don't know. I mean, it's just you know the thing about the thing that people don't tell you about privilege is certainly for me. Just get a lot of chance to think about things, and most people in their working life don't have that. So, you know, it's luck.
Like intelligence, compassion, and having time to think is definitely part of it. Any questions from anyone in the room? I don't see anybody's hand up. Okay.
Thanks so much. It's an amazing lecture. It's exactly what I anticipated from you. I'm just thinking, you have so many PhD students in the room and students at the center. If you could give them sort of 3 pieces of advice going forward, give them. It's a simple advice, so I know where you're
3 pieces of advice.
About 15 to 20 of them.
Okay.
About being in academia and being on it.
Okay.
I just want.
I'm looking at all my previous and current PhD students, and what if I said, finish? The best PhD is the finished PhD. Don't try and be like anybody else. So, you know, it's really, really important for you just to write from where you are in your own voice as simply and as clearly as you possibly can. And that's a whole other lecture. The whole of academia, particularly if you're not first language, is stacked against you because we write so badly and we were trained to write so badly. So good, clear, simple writing is really, really important. And don't clean your kitchen. So, and I'll tell you why I say that is one of the most difficult things in the world to do as a PhD student and as an academic is to write. We all hate it. And we all have ways of saying, I cannot write unless. One of the most common is I can't write unless my kitchen is clean. And so I was just at an early career academic development meeting on Friday, and I was so proud because one of the people came to me and said, you know, we had that writing retreat 2 weeks ago, and my kitchen is filthy. She'd managed to actually get 2 articles in. I'm not telling you to have dirty kitchens, but procrastination is fantastic in the short term and terrible in the long term. And I do it myself, so don't do what I have to do. But if you can write for 5 minutes a day, it's a habit. It's like riding a bicycle. Every day, even when you're collecting data, get into the habit, like the habit of riding a bicycle or anything else. Is that sorry? Yeah.
Thank you. very much. Can you please say more about populism in global mental?
Oh God. No. So, no, thanks, Dan. It's a great question. I mean, I think there are real dangers. I mean, I think we are so aware. I mean, I've come to this through my worries about right-wing populism, but it is so easy. I mean, think of our sloganeering. It's on the slide I took out. You know, during the struggle, some of you will remember there will be no mental health in South Africa until we have a non-racist, non-sexist democracy. And I mean, of course we need, you know, one needs social justice in order for there to be mental health. I completely agree. But there is a kind of magical us and them, is that when we're in charge, things will be much better. And I think the overvaluation of those kinds of discursive inversions is sometimes a form of populism, and then can lead, and I think we're often guilty as mental health people, to a misunderstanding of the embodied, the really difficult, hard work of having a serious mental disorder, for example. And I think we contribute to it, so it bleeds into other kind of sciences and so on. I hope that answers Dan's question.
One more question in the back.
Oh, hi. You managed very well.
Having enough translators for the number of people translating. But what about, or is there any investment in using the AI for example?
Yes, we're working on that. Yeah. Oh, a question I can answer. Next question. No. Okay. I don't know how many of you use things like Google Translate and those sorts of things. They have, I mean, it's astonishing how much better the AI is getting. But the AI is much stronger, surprise, surprise, on languages which are common in the global north. Much better than, so we've been able, in dealing with migrants from who choose to converse in French, it's been much easier to use AI than with people who speak Kinyarwanda, for example. But it's coming on, and there are fantastic people in AI in South Africa, and I'm having a senior moment, I can't remember their name, but the Vukusi Marivate's group is doing it, and another group whose name I forget there are lots of people actually looking at this, and I think it is going to create a change. The thing that gets elided, and it happens also with the use of AI in sign language interpreting as well, is, or that we're not there yet, and it's going to come, but we need to work towards, is the very contingent nature of code switching and turn taking in where there are multiple languages. And that happens with people who are hard of hearing and deaf, and it happens, you know, people who say, I can speak a bit of English, but I'm also speaking. Often, I mean, we've been struggling in our group just to get our data on this from interviews transcribed. We can't find people because people are code switching from one language to another in the middle of a sentence, as we do. I mean, I certainly do. So there's lots more work to be done. I don't think it's going to make humans redundant. I do think part of what we need to think about much more carefully is professional boundaries and who constitutes part of the health team and what kind of skills different people need to have. Because I've certainly been in situations where, because my receptive class is reasonably okay, where you know, the mental health professional saying one thing and an entirely different conversation is happening unbeknownst to the mental health professional. And then an answer is given. So it's extremely skilled, but it's not the same conversation. And there's clearly skills there that are being invisibilized. It's a long story, but thank you for the question.
Thanks, Leslie. Yeah, I think we're going to end off there. Leslie, I just want to say again, thank you so much. It's really been amazing listening to you, and I'm very sad you left out slides. I'll have to get them. So I just want to say thanks very much
Thank you.
for being here today and for being with us. Thanks
Oh,
so much.
thanks. It was such an honor. Thank you. Thanks very much.
So before we end, I'd just also like to thank everybody here for joining us. Thank you to Alison and John, who are joining us here in person, and Veronisa online, and any other family and friends that have joined us today. Special thanks to Kevin Ernston and Gillian Hanslow for doing a lot of the planning work and getting everything set up for us. I also just want to say on behalf of CPMH, or Alan J. Flisher Centre for Public Mental Health, Catherine Sorsdahl, Ashraf Qadi, and myself, thank you so much for joining us. It's really been lovely to have you with us. And as Kat said, we do have some light snacks and drinks outside. I'm sorry we can't Uber Eats to everybody online, but for those who are here, please join us. Thank you so much.